Good morning, everyone. It's a case of Cornual Ectopic in a 25-year-old female in which one tube is removed 4 years back on account of ruptured ectopic, and after that, with right single tube, she conceived and delivered one female child 2 years back. Now she came with a Cornual Ectopic, and it is a video of a reduction of Cornual Ectopic with KCL under ultrasound guidance and aspiration of the amniotic fluid. It is a type of minimal invasive procedure by which we can spare the major surgery, we can spare the catastrophic complications. What is Cornual Ectopic? Or it is a interstitial ectopic. When the ectopic pregnancy occurs in the interstitial part of the tube, that is in the uterine wall, that is around 1 to 2 centimeter and diameter is 0.7 centimeter. And when implantation occurs in this part, it is supported by myometrium and it seems to be invading the myometrial or endometrial part. So it is difficult to diagnose. Because of it has less sensitivity and less specificity to diagnose it early, and because of myometrial support it goes to second trimester, by which there may be rupture, there may be catastrophic bleeding. Now we can have the cornuectomy or the hysterectomy, or when sizes increase there may be a laparoscopic and abdominal surgeries. So what is it? It is 2 to 4% of the ectopic are cornual ectopic. How it is done? It is difficult to diagnose, and because the triad of abdominal pain, bleeding and amenorrhea, mostly they are not present with the bleeding and much of the pain, so they are lost or they are missed in diagnosis. With a good diagnosis, with a 3D ability and good imaging by ultrasound, we can diagnose it early and we can manage it with minimal invasive procedure by simple puncture needle, by aspirating the fluid and injecting KCL and reducing the fetus. It is a like of fetal reduction procedure that we do and multiple pregnancies. So it is very easy with the good guidance of good radiologist, and in this case Dr. Vishal Saraswat is assisting it. He diagnosed it by 3D, and now we are able to proceed it with injecting KCL in the heart of the embryo, and we are trying, we are waiting, we are injecting drop by drop KCL, then we are waiting to stop the heart, and we aspirated the amniotic fluid. And what about the things that we should keep in mind? We should explain the things to the patient. We should be suspicious to the cornual ectopic when the patient is complaining pain, and when see in a normal examination or ultrasound the pregnancy is a bit outside the endometrial canal, and by on ultrasound imaging, when the pregnancy is 1 centimeter away from the lateral wall of the uterus, or the myometrium over the sac is less than 0.5 centimeter or 5 mm, then we should suspect the cornual ectopic. Or patient generally complains the lower abdominal pain with amenorrhea. And nowadays we are doing the early scans, early ultrasounds in first trimester between for cardiac activity and all. And as she was a known case of ectopic, so she underwent the TVS examination in a first or second week of conception, and so she diagnosed early. She has given the methotrexate IM, and now because of the growing pregnancy and methotrexate doesn't work in most of the ectopic pregnancies, so we posted it for the fetal reduction or with the aspiration and injecting the KCL in the embryo. So it is a simple procedure. It is like day to day ovum aspiration that we do. Sometime we do ovum aspiration transmyometrium, so it was not a big deal for us, and with the able guidance and expert hands of Dr. Vishal Saraswat, we are able to inject in the proper place, and we are the focusing is so good that we are able to inject it so nicely. And we just took some time for to see whether the activity is there, and few puncture may be required because it is about to stop the heart. And good thing about corneal ectopic is it is not that mobile because it is within the wall of the myometrium. So it is the beautiful procedure. It is a simple procedure, and but the criteria and the main purpose is we should diagnose it early. We should diagnose it at times, especially in first trimester or less than 8 weeks, so that these procedures can spare the complication, the hemorrhage, the uterus, patient, and finally the doctors. So and now it is gone, the cardiac activity is gone. We are examining the POD. The minimal fluid is there, and it is the uterus with normal things. We are examining the parametrium, and now it's finally the endometrial canal and echogenic cornua that will resolve after some time. We will review this ultrasound after 10 days, and it was great to have teamwork and managed it nicely. And post-op care patient was fine, and it was discharged after 2 hours of the procedure.